So I'm using this opportunity to kind of reflect back on my career here as a lung cancer doctor. And as Nancy said, I started, it's been almost 15 years now. And when I started and looked at this opportunity I had to be a lung cancer doctor, one of the thoughts in my head is, well, how is this going to be interesting? It turns out that it is one of the most interesting things you could imagine, and there's been a huge amount of change. But when I started, lung cancer was a pretty, you could say, monotonous disease. We thought of it all the same. You know, if you think of what we call lung cancer, we're referring to non-small cell lung cancer. It's very interesting that there's this title. You're really saying what it's not. They had a taxonomy where there are all sorts of different histological subtypes, but in the end they decided they were all the same and just called it non-small cell. As I'll tell you, that's not the way we think about it now entirely. There wasn't very much variation in outcomes. Median survival was about 9 months for patients who presented with metastatic disease, which was the most common presentation. The perception was of lung cancer patients as being older, male smokers. And even though, you know, I had 2 colleagues when I started who had been treating lung cancer patients at the University of Washington for decades, we didn't have very many patients who graduated from our predecessors to myself and Dr. Martins when we started the program. And now it would be very much a different case. And much of the, I won't call it out, but much of the work our group had the opportunity to contribute to. So I will start out with lung cancer, the discussion of lung cancer incidence. So in this the top curve is males, the bottom females. And as you see, this red curve here is lung cancer incidence in males. You see it towers over all of the other cancers in terms of its number of deaths. And the other thing you notice is that the curves are falling. This relates to changes in smoking behavior. The lag time from smoking exposure to development of cancer is about 20 or 30 years. And so these, as we definitively prove that smoking caused cancer and had public health efforts to decrease smoking, these curves have fallen. One of the other things that you notice in the bottom curve is that the curve for females lags behind males in terms of the drop. And this had to do with really kind of 2 different trends. Women's liberation allowed women to smoke. And so they actually, you know, smoking rates in women didn't drop at the same rate as men. And for those of you who look at the New England Journal, you'll notice that there's a huge amount of cancer-related research there. And one of the interesting ones that came out recently was looking at the incidence of smoking in young women, young being less than 50. And this is now the largest group of people getting cancer. And it's not entirely linked to smoking. The exact cause is unknown. The other thing that I'll just point out here is that in my thinking about this, so as you know, cardiovascular disease is the leading cause of death in the US. And this is followed by cancer. And as we get better and better at treating cardiovascular disease, cancer will rise above in terms of leading. But if you were to take lung cancer as a single entity, it would be the second leading cause of death. So this is from the Lung Cancer Alliance, trying to debunk this idea that all patients with lung cancer are smokers. Only about 20% of lung cancer patients are current smokers, 60% are former smokers, and nearly 20% are never smokers. And if we were to, again, look at the spectrum of different types of cancer, you see that lung cancer as a cause of death really towers above the others. That, you know, the next 4 causes combined would add up to less than the number of deaths from lung cancer. And then this smaller blue bar is the incidence, the death rate of from cancer in never smokers. And you see it is a leading cause of cancer death. So one of the things I hope to do today is just get rid of this notion that lung cancer is a disease only for smokers. It is a, you know, if there was no smoking at all, we would still have significant amounts of lung cancer. And part of this is, one, to raise your awareness. So when you have a patient who has had a long respiratory history of respiratory complaints, being many months, and weight loss, and signs that would be suggestive of lung cancer, don't dismiss it and say it's not lung cancer because this person isn't a smoker. So this slide points to the distribution of stage in patients with lung cancer. So localized disease has a 56% survival, and here when we get the distant disease at 5 years, it's a 5% survival. It's probably even less than that from for the years that this is. But the most common presentation is distant metastasis, and the goal of much of the efforts around reduction of death due to cancer is to try to shift the stage of presentation through screening, and there have been successful efforts with this with breast cancer, colon cancer, and cervical cancer. But up until recently, data for lung cancer has been lacking. There had been a lot of interest in looking at sputum cytology and chest x-rays as a method to screen for cancers, and there were a number of large trials done definitively showing that this did not help reduce lung cancer mortality. You will find more lung cancers, but we were unsuccessful in reducing mortality. So as of 2011, there was no randomized data showing survival benefit and no randomized studies of CT screening. There were some prospective cohorts of screening showing that patients with screen-detected lung cancer could live quite long. So a screen-detected lung cancer in these screenings would have a 90% 10-year survival. But that is not sufficient to adopt screening. What we really need to do is to show reduction in mortality. And the National Lung Cancer Screening Trial was reported out in the New England Journal in 2011. This is really a groundbreaking paper for the treatment of lung cancer. This trial was conducted in 2002 to 2004. The cost of this trial was $300 million and would be significantly more today. For those reasons, you can see why it would be very likely to be repeated. They had over 50,000 patients across 33 medical centers in the US. And in order to make this work, you have to have a population that has significant risk for developing lung cancer due to problems with false positives. And so they defined the target population as ages 55 to 74, a history of at least 30 PAC years, and if they were a former smoker, they had to have quit less than 15 years ago. And they were randomly assigned to 3 annual screenings with low-dose CT or with chest x-ray. I just told you that chest x-ray didn't work. Why did they do this? It was thought to be unpalatable or unlikely to have a significant recruitment if the observation arm was just going to be observation. So this is one of the most important curves from it. In the top panel here, we have the cumulative number of lung cancers. And what you see is that the number of cancers detected by low-dose CT exceeds those from chest x-ray. This indicates two things. One is that this is a better technology for finding lung cancers. But what you'll notice is that as time goes on, these curves are coming closer together but don't meet. This is a suggestion of some overdiagnosis. More importantly, when we look at the lower panel, looking at death from lung cancer, we see that the patients who were screened with low-dose CT have a lower rate of death from lung cancer. So one of the difficulties with this trial is that it was noted there's a very high rate of positive screening. A positive screening was one in which there was a radiographic finding that needed follow-up that was different from a chest CT a year later. The false screening rate was almost 1 in 4 patients with CT and 7% with chest x-ray. Among those groups, the false positive rate was the same at about 95%. The rates of lung cancer incidence were different between the two groups, as I showed you in the prior slide. And lung cancer mortality was statistically significantly reduced. by 20% with a highly significant p-value. And what was also amazing, but even, purists would argue that even that is not enough. What we have to show is a decrease in an improvement in overall survival. And this was demonstrated with a 6.7% reduced rate of death, also statistically significant. And this led to the adoption of this by many expert groups, including many, which I'll talk about. So when we talk about lung cancer screening, we have to have a clear discussion of the risks and benefits. So this is one of those screening modalities where this idea of shared decision-making with the patient is key, because it's not as simple as just getting a test and having a simple outcome afterwards. So as I talked about, there's a risk of overdiagnosis, detecting a cancer that may not lead to death or any morbidity. All this testing can cause anxiety for patients. There can be complications from workup, biopsies, or surgery. And as I talked about, there is a high rate of false positive tests. There can also be false negative tests. And then all this can lead to unnecessary tests. There's radiation exposure. The radiation exposure from this CT is about a third of a regular chest CT, but nonetheless, it's radiation exposure and could cause malignancy as well. And then there's, of course, the costs associated. On the benefit side, most importantly, there's decreased lung cancer and overall mortality. Patients who are caught earlier with lung cancer have a better quality of life from this earlier diagnosis. It can lead to a reduction in anxiety, knowing that you don't have lung cancer. Many people who seek out this are concerned that they have lung cancer. There can also be incidental findings which turn out to be beneficial for the patient. They may have undetected coronary artery disease that's severe, or an aortic aneurysm. And most importantly, this can really be used as a teachable moment for smoking cessation. So what better point to talk about this with patients? And most programs will couple a robust smoking cessation intervention with this. So there are a lot of considerations. As I'll tell you, the uptake of this has been incredibly low. 3% of the eligible population has been screened at recent estimate, now nearly 7 years after the paper came out. And there were already efforts undergoing that prior to that. So there really, to my knowledge, there is no confirmation study planned for this because of the tremendous cost. And then some would also say that it would not have clinical equipoise. You would not want to be randomized to the non-screening arm. As I said, most organizations have endorsed this. The only one noticeably who didn't is the American Association for Family Practice. And they talked about this problem, whereas these studies were done at specialized centers. There wasn't a huge amount of standardization, but there was standardization around reading and so forth. And the worry is that when deployed widely in the community without adequate safeguards, is that the benefits would not be yielded in that setting, and that the harms would outweigh the benefits potentially. So the other aspect is that these criteria that were used for the NLST only cover 27% of the people who get lung cancer, and adoption of this would avert 12,000 deaths per year if it were fully implemented. So a lot of the organizations looked at how can we create risk models to have a similar amount of risk to that seen in the NLST by changing the criteria, because if you had a strong asbestos exposure history or occupational exposures, that could also increase your risk. And then there are other possible reasons for the low uptake involving disparities. These are typically older patients. Smoking tends to be more prevalent in lower socioeconomic status, racial issues, and also, importantly, the stigma that smokers have of bringing this on themselves. So the sense of agency is not there. So if you look at it compared to other cancer screenings, And these are US PTF, which is really the gold standard for recommendations for cancer screening. You see, lung cancer gets a B grade. That's similar to screening mammography, and we have, many programs have quite high rates of screening mammography. Below colon cancer, but above prostate cancer. And if you look at number needed to treat, or number needed to screen, it compares favorably to these other modalities. So when screening a potential patient for lung cancer, it's important to be part of a larger program. It is not sufficient to just say, oh, I will just order a CT on this patient and see if you have lung cancer. That will not likely result in the same benefits because you do not have a team of people working behind you to make sure that the proper algorithms are followed. It's important to have an appropriate target population, meaning one that's at high risk. If you screen low risk people, the harms will outweigh the risks. The other thing is the radiologists reading these, just as we have over time developed a standard for reading mammograms, there have been standards developed for screening CT scans, known as lung rads. And then, as I talked about, we have to have a care team to do that. And another emphasis here is this is not a simple, order a test and send the patient away. It's a conversation with the patient, and it should be coupled with smoking cessation if the patient is smoking. This is just an example. So for those of you who are not in the cancer space, the NCCN, the National Comprehensive Cancer Center Network, has created a lot of pathways or guidelines on the expert treatment of cancer, including cancer screening. This guideline, and actually Dr. Wood, I mentioned earlier, is the chair of this committee. They have developed a number of algorithms on how to identify populations, and then also, based on how large the nodule is, what the next steps are. And so these are based on best evidence and expert opinion when best evidence is not available. So this is just for illustrative purposes. And the other thing that I will just shamelessly plug is, Dr. Mattis and colleagues at the SCCA have started the Lung Cancer Early Detection and Prevention Clinic. So this is a program to help follow up patients who have abnormal findings on CT scan. This is our version. So one of the other breakthroughs that has happened in lung cancer is this idea of stage shift, or better staging of patients. So you could imagine these cups with balls being the original state of those stages of patients. So the stage of the patient determines, the extent of disease and the ultimate treatment. And so when we used to stage, when we started out, it was just chest X-ray, then that moved on to CT. Then we developed PET scanning, which was a tool that could reveal occult disease, and MRI scanning of the brain as compared to CT scanning the brain will reveal more occult metastasis. And so what this results is the patient that you previously thought was stage 3 may have a small brain metastasis and then go into stage 4. And so what this does is have the effect of making every stage do better. This is known as the Will Rogers phenomenon. And what we see along the x-axis is time, and so over time you see that PET use has increased significantly, and the number of patients in stage 4 has gone up, and the number of patients in stage 3 has gone down. And so this has resulted in improved survival in each of those groups. So the top two are stage 1 and stage 2, and you see the survival curves with PET use or no PET use are not very different. And in the lower two panels, you see that when you use PET to stage patients, patients in both stage 3 and stage 4 do better. And so this is not truly a treatment advance in terms of making patients live longer. It's a better classification of patients so that they can receive the appropriate treatment and not be over or under treated. So when I started, basically the job of a medical oncologist was to treat patients with advanced cancer or stage 3 cancer with chemotherapy for palliative effect. And at that time, it was really all about chemotherapy and palliative care, with more of an emphasis on chemotherapy. And there was evidence that single agent chemotherapy was better than best supportive care by about 2 months. And then this idea of doublet therapy, having 2 agents together, was better than singlet therapy. They even went to more agents. More agents, turns out, it just increases toxicity without improving survival. And this was the big study that came out when I was a fellow, looking at all of the competitors to see which one was going to be the winner. They were all the same. And what is also notable here is that the median survival, even in patients in a clinical trial, was, as you see, about 9 months. And typically clinical trial patients will do better than your run-of-the-mill patient. So as I was starting, it was really kind of the dawn of a new era. There were some insights into the molecular biology of cancer, including the idea that certain pathways were activating in lung cancer. And one of those pathways was EGFR, the epidermal growth factor receptor. A small molecule tyrosine kinase inhibitor, gefitinib, was introduced in the early 2000s. And it was studied in phase 1 all solid tumors. And these are typically, at that time, patients in phase 1 trials had exhausted all options and were expected to have quite short life expectancy. Response rates were in the 3% range, okay? And in one trial, they saw 4 of 16 patients had a partial response, which was considered quite remarkable. And then in Japan, they had a trial, again, with 5 of 23 patients. They didn't quite have an insight as to why this was the case. And it was really thought that this EGFR mechanism was a general mechanism, and that the idea of targeting this to a specific audience of patients had not yet been developed. So there were about 10% of patients in these trials which are what we termed exceptional responders. And so oncologists always love to throw up a picture, and you'll see I'll do this later, of a big tumor that's then a small tumor from just taking a pill. That's what we really like to see. And the FDA approved this drug kind of based on, you might say, not such great evidence, but some of these exceptional responders. Lung cancer was considered a very bleak clinical environment, and so they approved it, but they said, you're going to have to do a real trial showing that you can actually help patients live longer. They did that larger trial with unselected patients, and it actually didn't work. And so they rescinded this drug. It's very unusual in our experience as doctors that a drug that's on the market would be rescinded for lack of efficacy. Alongside this, so imatinib, which was a targeted, also a tyrosine kinase drug, was approved for CML, which is a cancer that's characterized by a very specific genetic mutation, which is targeted by this drug, and that absolutely revolutionized. So there was an example of a drug and a target where it worked perfectly, and then, as I told you about the early experience here, without a target, it didn't work well at all. So, but in 2004, investigators found that there was sensitivity based on specific mutations. And so this was kind of the start of getting a lot of cancer papers in the New England Journal. So this is a paper by Tom Lynch and colleagues. And they had some of these exceptional responders. And so DNA sequencing was getting better. And they said it must have something to do with that EGFR gene. They sequenced their tumors and found a specific set of mutations which conferred exquisite sensitivity to these cancers. So even though we had this prior case of Gleevec, which was really a design drug for CML, this was really the first case of a driver mutation in a solid tumor, and as such represented a great milestone. So this is my best case in this arena. So this, in 2006, early in my career, a 56-year-old never smoker presented with dyspnea, cough, and headache. She had a remote history of colon cancer and had a 5-centimeter left upper lobe mass, mediastinal involvement, and with a brain scan also was noted to have 3 small CNS metastases. The biopsy showed adenocarcinoma. At the time, we treated her with a localized therapy to the brain, which treats just the tumors, called Gamma Knife. And at that time, this was just after I told you about the discovery of this mutation. Now we were targeting patients to this, and we had a trial that we were collaborating with MGH. But She didn't have adequate tissue for testing, but based on her demographics, that she was a non-smoker, as it turns out, lifetime never smokers are highly likely to harbor these mutations. Also, being female and Asian also increase the risk of harboring these mutations. So she was treated off-label with a new drug called erlotinib, which targeted the same pathway. And there was a rapid reduction in her tumor mass seen here from 5 centimeters to 2 centimeters. She had an excellent response, but a year later had a local relapse. A thorough investigation showed that this primary site was really the only site of progression. And she underwent stereotactic radiation to this in 2007. But then 2 years later progressed, and we actually sent her to resection. And it was a complete resection. She did not have involved lymph nodes. At that time, the testing showed the mutation that she had, which now we know is what's called L858R. It's a activating mutation. And it also had this T790M resistance mutation, which is interestingly an analog to resistance mutations seen in Gleevec patients in a different protein. And so since that time, she's required several gamma knife procedures for new brain metastasis. And she continued on erlotinib until 2017. So this is 11 years later on this same drug. And then progressed with an isolated calivarial metastasis. And at this time, a new drug had come out, which was specifically targeted towards this resistance mechanism of T790M called osimertinib. And she remains on that to this day and has had 12 years of targeted therapy for metastatic non-small cell lung cancer with scans showing no active disease. So when I started, this was basically unheard of. There was a lot of interest in trying to bring these drugs. So typically the way things work in oncology is when we have a new drug, we sort of tack it on to the end after everything else doesn't work, and it kind of works its way forward in treatment lines. This was a trial done in Asia called the IPASS trial, and it was an example of they were taking patients with these risk characteristics. When the time this trial was designed, they did not yet know about the mutations. They said, well, let's just take these people we know respond, adenocarcinoma, never or light smokers, and of course it was done in Asia, so they selected for Asians. They were randomized to the gefitinib, the drug that I told you they brought on the market and took off, or standard chemotherapy. And what was noted is that in these patients, and then interestingly, so this story about the mutations came out afterwards, and then they were able to look at bank tissue and then determine their mutation status. So patients in the mutation positive arm had a 71%. If you didn't have the mutation, your response rate was 1%. Okay, as it turns out, interestingly, having a mutation also helps you respond better to chemotherapy. These were all highly significant, and these are the progression-free survival curves showing a significant benefit to the gefitinib. The other aspect is it's a much better tolerated drug. The survival curves do not show a difference because all the patients cross over for ethical reasons. So the way we think about lung cancer now, as I talked about, when we started out, we were just thinking about non-small cell lung cancer as a single disease. And then there was this idea of histology-based typing, where we have squamous and adenocarcinoma and others. That was part of the talk that I took out because I don't think it's of interest to the generalists. But now really, certainly among adenocarcinoma, we're looking at molecular subtypes. And I've talked to you specifically about the most common targetable mutation, which is EGFR. There are many other targetable mutations, which I will gloss over briefly, but this is really the way we think about it. And to go back to this earlier theme that these Asian never smoking patients are really a different type of cancer, this was a study done in 2010 when we even had less knowledge of all the different drivers out there. But you see, only at that time, less than 10% of the patients did not have an identified driver mutation. This this was a study done with money from the Recovery Act. If you remember, during the recession, they were trying to pump some money into the economy, and they were giving away money. And so this was a study done where they collected tumor specimens from a number of different cancer centers and subjected them to sequencing, and then kind of correlated this with outcomes. And so this is looking at the natural history of patients with these driver mutations versus not. And so the orange curve there is patients with driver mutations who are treated with a targeted therapy with lung cancer. And they have a median survival of 3.5 years. The two blue curves there are patients with no driver and patients with a driver that did not receive targeted therapy. So you see with these, and this was, as of maybe the data is probably from 8 years ago, our targeted therapies at that time were adding about 1.5 years to these patients' lives. We've learned a lot more about these cancers and how, so eventually what happens for most patients on these drugs is that resistance emerges. And by rebiopsying patients and subjecting their tumors to next generation sequencing, we can learn a lot about these resistance mechanisms, and these resistance mechanisms are subsequently targeted. This EGFR T790M mutation I told you about earlier is the most common one, and we've already created drugs to target these. And there are a number of other different oncogenes which can come into play and potentially be targeted. So as I told you, this osimertinib drug was created to target T790M, and then as cancer drugs do come in at subsequent lines and then work their way forward, this was a trial looking at this new drug against a standard EGFR tyrosine kinase, and it showed better progression-free survival and overall survival. It also, interestingly, has less toxicity, and so it has been widely adopted. Interestingly, one of the things that I could give another separate talk on is that these drugs are tremendously expensive. So the cost of this drug is about $15,000 a month if you're getting a decent deal on it. One of the things that has come out is that there are, so these responses to the tyrosine kinase drugs is quite remarkable, and there are a number of exceptional responders. So this is data. So I told you that this drug, gefitinib, came on the market and then was taken away. There had been, at the time they took it off the market, there were a number of patients that had been on it for years, and it was, thought to be unethical to allow, to take them off a therapy which they're benefiting. So the company created a program that allowed them to continue. And this is tracking of those patients who had made it to a certain milestone. You see that some of these patients are making, so that this patient that I described to you is not an entire anomaly. So there's an accelerating pace for these targeted therapies. The first such targeted drug was this drug imatinib, or Gleevec, which targets CML. So the Philadelphia chromosome was discovered in 1960, and we had this targeted treatment in 2001, a nearly 40-year gap. EGFR was found in 1978 and treated in 2004. These two other examples are from lung cancer. This ALK gene was discovered in 2010 in basically a mouse xenograft model, and targeted therapy started in 2010. And then this ROS1 mutation, which is a rare mutation seen in lung cancer, was found in lung cancer and targeted just a year later. So the increasing knowledge of molecular biology and drug libraries and genetic sequencing has led to rapid improvement. It may be that we are kind of reaching the end in lung cancer, and lung cancer has been a particular success story. But so here's an example of a number of different genes that we have, so 4 that are in current FDA-approved drugs, and 4 more that soon will be targeted. And so the pace of this in lung cancer has been remarkable. One of the things that has become part of what I do is you have to become an expert in molecular testing. When we get a patient's tissue, the first two slides are showing, basically doing the usual pathology, H&E analysis. And then there are many other steps that have to be done, and it has to be done in a very, both cost-efficient and tissue-efficient way, because we only get so much tissue, and you have to do testing on it, and it has to be done in an efficient way. And so it has led to a lot of collaboration with our lab medicine and pathology colleagues. Another new exciting technology that we can sometimes employ, so as I talked about, tissue can be scarce, and I think it's been a subject of grand rounds here in the past, is that tumors actually, as they're dying, shed their DNA into the bloodstream, and this exists as circulating tumor DNA. And using highly specific techniques, we can find these genetic aberrations in the circulating tumor DNA. And this is, it depends on the patient's tumor burden. It's really only used in the metastatic setting, but this gives us the ability to look at clonal evolution in patients, and in patients who don't have adequate tissue, we can test them. So the next thing I want to talk about is immunotherapy. So there has been this notion or idea that sometimes cancers will spontaneously regress. There are stories of saints who had tumors on their legs that would spontaneously regress dating back to the 1200s. But then as modern medicine came and we were able to do biopsies and definitively diagnose cancer versus an infection, people began to collect these case series. This was one done nearly over 50 years ago, where they had carefully looked at cases, and it was known to happen in kidney cancer and malignant melanoma. These are the most common. And so using the supposition is that this was related to the immune system, and that the immune system was somehow activated to fight the cancer. For the most part, when I started, this was really mostly a dream. So certainly there were evidence of this in allogeneic stem cell transplantation. So a transplant works in two ways. One is through high-dose chemotherapy. The other is through a graft versus leukemia effect. When I was a resident and fellow, our big nightmare was taking care of patients on IL-2, which was a synthetically produced cytokine that which gave to patients, and they would typically be in the ICU on pressors in order to stimulate an immune response. And what we would see is that, a single-digit percentage of these patients would have a remarkable response, and some of them may have even been cured. We also had interferon with all of its attendant side effects. And the other example is using BCG to stimulate an immune response in the adjuvant treatment of bladder cancer. There were quite a few vaccine trials, none of which had positive results. So we had the opportunity to participate in a phase 1 trial of a new class of immunotherapeutic agents. And a 55-year-old woman came to me. She had stage 4 disease with a so-called Pancoast right upper lobe superior sulcus tumor, and she had been treated with chemotherapy and radiation. I had a vaccine trial at the time, and we put her on the vaccine trial, and she progressed with Horner syndrome and an adrenal metastasis. She had a good performance status and enrolled on a trial of an anti-PD-L1 antibody. So to explain what that means is, so the cancers are mostly self, meaning they derive from normal tissue, but what makes them cancer is they have genetic aberrations, which causes changes in proteins. And some of those proteins are potentially immunogenic and can be presented by MHC. Well, as it turns out, the tumor has mechanisms for defeating this system, and one of them is through so this is the tumor cell here, and this is a T cell interacting, and so you have the MHC interacting with the T cell, but it can display this PD-L1 protein, which has the effect of downregulating the immune system. There are all sorts of checks and balances, accelerators and brakes on the immune system, which, as it turns out, tumors oftentimes use to shield themselves from the immune system. And so the idea behind this class of drugs called checkpoint inhibitors is to change the ratio of these brakes and accelerators to basically unmask tumors to the immune system. So this was the trial which we participated in. This was, it was given as phase 1 trials were at the time in a number of different solid tumors. And what we saw was amazing. So along the x-axis is basically time, and the y-axis is the size of the tumor. And so the natural history of a tumor would be those tumors would be getting larger and the curve would be sloping upward. And as you see, there are a number of, each one of those curves represents a patient, and there are a number of patients whose tumors diminished in size. And the other thing is those curves, you can see that the patients remain on these drugs for over a year at the time that this was published. And so this was a truly remarkable study, and phase 1 studies don't often get published in the New England Journal, but this was considered, there were actually 2 papers on this subject in the same issue. So, for this class of drugs, there was a clear signal seen in phase 1 clinical trials, and unlike usual clinical trials where we just put in enough patients to figure out what the dose is and then do a phase 2 trial, a new type of trial design came out where you could extend the cohorts and just keep putting in patients if it looked like it was promising. At the time this happened, there was not a good biomarker to predict response, and I would say that's probably still the case. But unlike the tyrosine kinase experience where I told you just a select group of patients have these mutations, this is a treatment that could be deployed to all cancer patients or all lung cancer patients. And it's pretty much what they're trying right now to figure out. There's really not a place where we definitively said that these therapies don't work. So randomized clinical trials have established these in a number of different settings, which I will kind of go over, and I'll kind of gloss over these slides because there's other things I want to get to. But so this is one of the first trials. And so as I say, we typically when we introduce a new therapy, we come in later lines of treatment. And so this is looking at patients with advanced lung cancer who had progressed on first-line therapy, and they were randomized to a standard chemotherapy, docetaxel, or this immune therapy. And these curves separated very nicely with favoring the immune therapy. And the other aspect is that you see the grade on this table here, the grade 3-4 adverse events. For regular chemotherapy, over half the patients had adverse events. And then for the immunotherapy, 10% of the patients. So it was considered a much more friendly therapy. And then the other aspect of things is that there was a potential plateau in these curves. We see some patients with very long responses. This next trial it involved moving it up to another agent up to the first line. And now we had identified a potential biomarker, namely PD-L1 expression on the tumor. And here, compared to standard chemotherapy in this population, again, they're doing much better in terms of outcomes with less toxicity. This has also found its way into the adjuvant treatment of stage 3 cancer. With improvement in progression-free and overall survival. So it's found a number of places, and including now we've also combined it with standard chemotherapy in the first line. So there's hardly a patient that will not be treated with immunotherapy for lung cancer now. So people in the cancer world know a lot about this paper, The Median is Not the Message, by Stephen J. Gould. Dr. Gould was at Harvard and diagnosed with mesothelioma with a median life expectancy of months. And he noted in these mesothelioma survival curves that they had a tail. And he said, you know, I understand what a median is, but I also understand what a tail is, and the median is not the message. You know, what I'm going to be is I'm going to be on the tail. And it turns out he lived for 20 years after that. And so that's kind of become the hallmark of, in oncology, we want to strike a balance between being realistic with our patients and then also able to have some room for hope. And so this was a paper published recently looking at looking at some of the experience with an agent, nivolumab, from the phase 1 clinical trials. And what you see is that the 5-year overall survival rate is 16%. I told you before, really, we would say the 5-year survival rate, a decade ago would have been about 1%. So these are patients that are doing remarkably well. And what I would say, so this is the specific example. So time 0 here is when they went on the trial. The blue part is the treatments they had before. The yellow part is on treatment. You see those all truncate. The trial stopped at 2 years and they stopped getting therapy. Well, most of these arrows mean that they're continuing to live. So the other interesting thing is that this probably sets up an immune state which continues to fight the cancer, and these patients may possibly be cured of their lung cancer. So it really represents a remarkable thing. I would be remiss in talking about this if I didn't talk about side effects. As I said, about 10% of the patients on single-agent immunotherapy have immune-related side effects. This is from the NCCN patient-facing material, and you can see there are arrows pointing to every part of the body. And basically, if you think of any itis that you could get, that is basically what can happen with immunotherapy. It can activate the immune system against any protein in your body, potentially, and that would be self-recognized as non-self. So you can have encephalitis, you can have pneumonitis, you can have dermatitis, nephritis, and all our specialist services are getting to see what immunotherapy does. So when you see a patient who's received these therapies, really anything is possible, and it's resulted in a lot of publications for a lot of interesting fascinomas. So back to the case that I was talking about. So this is how she presented when she went on the trial. There's this lymph node mass and also an adrenal mass. You can see the lymph node mass decreased, as did the adrenal mass. And she remained on treatment and then went off per the protocol. And she, in 2005, did our fundraiser bike ride and remains a patient of my colleague. So one of the questions you might ask is, why has all of this happened in lung cancer? So I would say, although these principles apply to other cancers, they apply particularly to lung cancer. It has been one of the most fruitful areas for immunotherapy and targeted therapy. So this is a plot of somatic mutation burden, and it's a log plot. So these are orders of magnitude, and across this way are cancers arranged by median mutational burden. And you see here the top cancers. So what I did talk about is melanoma. Melanoma is really where all these therapies, immunotherapies, were developed. Melanoma is the cancer with the highest tumor mutational burden because it is basically constantly, the tumors have constant ultraviolet light exposure, which causes a lot of DNA damage. Lung squamous cell cancer is the more smoking related of the two. And then this is presumably due to exposures to carcinogens. And then bladder cancer is another field defect kind of cancer where you have these same chemicals in the urine. And so these are the ones with the highest mutational burden, and then also with the highest likelihood of response to therapy. So the other thing you notice is there's a huge range of mutational burden within these cancers. So this is something from the Cancer Genome Atlas. This is never smokers versus smokers, and you see these are the number of mutations. You can see you barely see this here in the never smokers, and in the smokers, they're orders of magnitude difference. This is in part why smokers respond better to immunotherapy than never smokers. It turns out the type of these mutations is different as well. Touching on this briefly, so this is something that appeared in JAMA Oncology. So there's a lot of interest in molecular testing generally for patients. But as it turns out, only a small percentage of those patients will turn out to have actionable mutations. And of those, even fewer will benefit. And what I would tell you is that most of these people benefiting are in the lung cancer space. So in my closing 8 minutes, I will talk about something entirely different. So all this was really molecular-based oncology, and now I'm going to turn to systems-based. So there are a lot of things you can do with new drugs and technologies, but there are a lot of things that also are really learning how to do what we do better for patients. So this is an example of patients undergoing surgeries, and it's stratified, the survival curves are stratified by volume. And what's noted is if you go to a center with more procedures, your outcomes at 5 years may be different by up to 20%. This is remarkable, and if you're thinking about getting an operation, probably a very important thing to know. And the likelihood of why this is the case, it's not entirely known, but it probably speaks to systems. First of all, doctors as technicians who do something over and over again and get good at it, but also systems that are able to take those all into account. Backing up to a larger scale, if we look at cancer institutions, so this top curve is what we're in, this PPS exempt. So there are 11 hospitals, MD Anderson, Sloan Kettering, our hospital is actually one of them, that have this special status with the government as standalone cancer hospitals. Then the next is NCI designated, academic medical centers and community. This was a study done at Memorial Sloan Kettering using Medicare data. And this is for lung cancer, and what you see is, so these are upside down survival curves, but what you see is, and this is for all different stages, what you see is that your likelihood of death is up to 20% different based on where you're treated. And again, we think this is related to differences in opportunity and expertise. How do we do this? One of the things that we've done at the SCCA is to create pathways, so evaluation of the evidence, and so that every one of our doctors is doing the same thing in the equivalent situation. The other thing that turns out to be very important in lung cancer is this idea of early palliative care. So many of our patients with stage 4 disease are destined to die in a short amount of time. And so the typical scenario was to be working on the anti-cancer treatment and then to make an abrupt change to end of life. The newer paradigm is to kind of start out with this idea of palliative medicine from the very beginning, focusing on the whole patient and symptom burden, and having that balance change as the patient progresses. This was validated in a study published in the New England Journal now 8 years ago, where they randomized patients to usual care versus this early intervention, involving basically meeting with the palliative care team at least monthly. And then what we see is that, so first of all, the survival analysis was not done as a primary objective. It was done just to make sure that it wasn't worse. As it turns out, it was statistically significantly better. And so this really became an important part of the way we think about treating. It's been validated in other studies. As you might expect, quality of life, healthcare spending, and other aspects are improved as well. So as I'm coming to a close, another thing that we're working on at the SCCA is this idea of patient-reported outcomes and remote monitoring of patients. So this is a study, again, done out of Sloan Kettering, where they had patients fill out basically symptom surveys, and then the nurses would react to that in a variety of cancers of different stages. And what they saw is that in this randomized group, that patients lived 5 months longer on average just with this intervention, which was quite remarkable. So Atul Gawande has this idea of fast versus slow ideas. So as it turns out, anesthesia, you put the patient to sleep and then you can do a surgery without a struggling patient. It was adopted in like 2 years. Whereas this idea of antisepsis, that there is this hidden thing called, bacteria, and you have to keep very clean so patients don't get sepsis, that took decades to take place. And so these last things that I tell you about are more like the slow ideas, and of course all the drugs are fast ideas being promoted by drug companies. I think they're both equally important. I'm going to skip to the end. So oftentimes as a medical oncologist, patients ask me, so there's no hope, doctor? And I say, well, hope is in part what you hope for. The first patient I talked about, the one who is still alive now, at her 5-year anniversary, she made me a book of all the things that she did during those 5 years. It was called Hope. And that's one of the things that keeps me going. So I will end on that note.